years ago, there was a new law in relation to diseases called the Auge Plan or JESS Plan that gave warranty to proper treatment to people with prevalent diseases which have an effective treatment. So some diseases were selected for that, and these were where the state put more resources. And one of those was MI. And the two things that were got a guarantee were to provide at least thrombolysis at any hospital in the country, anyone, from the most sophisticated one to the most basic one, hospital, not primary care centers, during the acute episode. At least having thrombolysis, unfortunately with streptokinase and not with a more effective thrombolytic. Of course, if you are able, if you work in a hospital who is able to do primary angioplasty, it's also allowed, but of course cannot be assured for the whole country like Chile. And to provide effective drugs for secondary prevention at any primary, secondary, or tertiary care facility. What are the resources? The primary care facilities in Chile have general family doctors, nurses, nutritionists, EKG, a basic lab, and effective drug. The EKG is connected to a central reporting office in a place in the country, so every doctor who is not used to report EKG can have the report in a minute in order to say if is it an MI or is it not an MI. For all these people who are under control in primary care centers, it's not easy to have appointments at the main hospital, and they remain most of the time under this. Temuco is there. It's long sword, it's Chile. Temuco is in the middle. We made a survey last year, 245 patients with previous acute coronary syndrome, medical or surgical revascularization, were under control at the primary care centers in Temuco, and this was 1 year after the event. And we saw that a good thing was that most of the people had quit with tobacco. Tobacco was just in about 10% of people, but the rest were not very impressive. Hypertensive were half of them, diabetics had a bad control in half of them. A normal body mass index was just 15%, 15 to 20%, and the circumference of the measurement was also high in both men and women. What was not bad was the use of drugs. So you saw that 87% of people used aspirin, 78 statins, 67 beta blockers, and 74% ACE inhibitors. How good is this? Are we very bad if compared with developed countries like Europe? And here I want to share with you in the next couple of minutes the Eurospire results 1, 2, and 3, which tried to measure the impact of the guidelines of the European Society of Cardiology in the behavior of doctors and population in Europe. And these are survey 1, survey 2, and survey 3 in 3 colors. As smoking was the same, about 25% in the 3 of them. That was a bit about 5 years one to the other. Obesity went up, and central obesity went up. But drugs were used much more. You see, platelets, beta blockers, ACE inhibitors, statins. And you see that due to that, probably elevated cholesterol went down. So patient did not change style of life, but used more drugs. So cholesterol went down, total cholesterol, raised cholesterol remained the same, and diabetes went up. And if we see the pure study, but our department took also part of that of this study. Pure study looks to the use of proven drugs about 5 years after the attack, and you see it overall 3 or more drugs in about 60% population. But if you know, you see clear countries in high income, upper middle, low and low, you see that low income countries, 80% of people don't take 3 drugs. Most of them take either no drug or 1 or 2 drugs. So what we saw after 1 year, it's possible that it's not going to be the same thing after 5 years. Chile is and Argentina here, and here is Canada, Australia. High income is Australia, Canada, we're Argentina, Poland, and Chile too. So in Europe they decided to try a strategy that's a Euro action, which is, I think that's the most important thing, a nurse coordinated family-based preventive cardiology program, in which nurses were in charge of families, both in hospitals and general practice. And they involved the whole family in the way of life of people. And in red is what they found. It changed after 1 year, although not very impressive, but people ate more fruit and vegetables, people made more activity, people had better blood pressure, LDL cholesterol was lower, and the use of drugs was also a bit higher. These are the patients with chronic disease, it's another group. So, if we think secondary prevention wants to prolong life expectancy, reduce morbidity and mortality, improve quality of life, well, we need a teamwork between primary, secondary, and tertiary care centers. Start prevention before discharge. Nurses are key actors for success. So, in conclusion, it's difficult to control risk factors even in populations highly sensibilized and at high risk. Use of medication is often privileged over changes of lifestyle in developing and developed countries. And our future is probably the use of intelligent intervention at the younger age of life, like, for example, countries like Finland.
Thank you very much.